Good morning, Professor Collins.
Good morning, Sir Brian.
My apologies for speaking from behind a mask if you can't hear me very clearly. I hope you can. Obviously, you
Yes.
can see me. But now, let me describe the scene to you that you're facing. But first of all, you're at home, I think.
That's correct, yes.
And your wife is in the house.
Yes, she's here, yes.
Right. You are talking to an inquiry chamber, which, although I know you'd hoped to be here to see it in person, it's a big room, will seat about 200 people, and at the moment we have a total of 8 people in it, all very socially distanced, as you might imagine, all wearing masks, except at the moment for Miss Scott, who's going to ask you the questions. Mary, in a moment or two, will ask you to take the oath. Beyond the inquiry room, there will be something in the region of 1 to 200. There were just over 200 yesterday watching, either on a direct Zoom platform or on YouTube. So those are the people you're speaking to. I imagine there'll be probably a number of people from Wales in particular who will be interested to know what you have to tell us about that. So, Mary, please, would you ask Professor Collins to take the oath?
Please state your full name.
Peter William Collins.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
The evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Miss Scott.
Good morning, Professor Collins.
Morning.
I'm going to start off by asking you some questions about your CV. So we know from your witness statement that you completed your medical training in 1986.
That's correct.
Can you recall what you learned during that medical training about the risk of viral infection via blood and blood products, particularly in relation to HIV and non-A, non-B?
I was aware from medical school training that hepatitis could be transmitted by blood products. I don't think I was aware at that time about HIV being transmitted. I was aware that I was aware of AIDS that had been mentioned in my undergraduate training.
And can you recall when you did become aware that HIV could be transmitted through blood and blood products?
It would have been sometime over the next year or so.
And can you recall during your medical training what, if anything, you were taught about the seriousness of non-A, non-B as a disease?
I can't remember specifically what we were taught about non-A, non-B. We were taught that after transfusion there was the risk of hepatitis. I can't remember anything that was described about the risk of the severity of that or whether it would develop chronic hepatitis.
And can you recall whether you ever had an understanding that it was anything other than a serious? It could be a serious disease and could be chronic.
Yes, I think I always understood it could be a chronic disease and could be serious, yes.
You then undertook various house officer roles in surgery and medicine between August 1986 and February 1989. Is that correct?
That's correct, yes.
And was your first haematology post February 89 as a senior house officer in the Royal London Hospital?
That was the first formal haematology, although on my medical rotation at Old Church Hospital, I covered some haematology there as well. But my first formal training post in haematology was at the Royal London.
And was that under Professor Colvin?
Well, it was Professor Newland was the managed the leukemia side of and the bone marrow transplantation, and Dr. Colvin the coagulation and thrombosis side.
And you then became an honorary lecturer in haematology in February 1990 at the Royal London. Is that correct?
That is correct, yes.
And was that a post that involved teaching?
No, it was really a research post rather than a teaching post.
And so, during that post, how much of your role involved the treatment of those with bleeding disorders?
I would cover bleeding disorders out of hours on call, and I would go on ward rounds where people with bleeding disorders were being treated as inpatients.
You then had a post between September 91 and June 93 as the Leukemia Research Fund Clinical Research Fellow at the Royal London. Did you spend any time during that post working with those with bleeding disorders, or were your duties in relation to those with leukemia?
Well, I was employed at that time doing a thesis on thrombotic complications of bone marrow transplantation. So that was the focus of the work then. However, I did continue throughout all of that time to be involved in the care of people with bleeding disorders, particularly out of hours.
Were you involved during that time in any of the testing of patients for HCV, hepatitis C?
No, I wasn't involved.
Then between July 93 and July 95, you were a lecturer and honorary senior registrar in haematology at the Royal London Hospital. Is that right?
I think, or is that the Royal Free Hospital, or is that next?
No, it may be the Royal Free Hospital. I've got Royal London, but it could be that it's Royal Free. It's Great Ormond Street I've got next.
Well, no, from the Royal London, I rotated for 2 years to the Royal Free Hospital, and then after 2 years, I rotated for 1 year at Great Ormond Street Hospital.
That must be the Royal Free Hospital then. And then August 91 for a year at Great Ormond Street Hospital.
1995.
95, sorry.
Yeah.
And then in September 1996, you took up your consultant haematologist post at the University Hospital Wales.
That's correct, yes.
And at the same time, you became the director of the Cardiff Hemophilia Centre, which was then called the Arthur Bloom Hemophilia Centre. Is that correct?
Yeah.
So between 1996 and 2001, can you estimate how much of your time was spent working within the Haemophilia Centre and treating those with bleeding disorders?
It was probably about 80 to 90%. My other roles, because I had to manage people with venous thrombotic disorders, anticoagulation, and see people generally around the hospital who were having abnormal bleeding. So, for example, after childbirth or after cardiac surgery, I would be involved in treating bleeding in those situations.
And do I understand from your witness statement that between 1996 and 2005, you were the only consultant on call for those with bleeding disorders?
That's correct, yes.
And then in 2005, that changed because you took on, Dr. Raymond took up her post as a consultant at the centre.
Yes, so she took up her post then, and after that we shared the on-call.
And then in September 2001, you were appointed a Professor of Haematology at the School of Medicine and in Wales, and an honorary consultant haematologist at the Cardiff Haemophilia Centre at the University Hospital Wales.
I was initially appointed as a senior lecturer, and then after that was promoted to reader, and then subsequently promoted to professor. So it was all the academic track after that, yes.
And is it right that from September 2001, approximately 50% of your time was devoted to your academic duties, teaching and so on, and 50% of your time to clinical work?
That was what my job plan was, but I spent substantially more than 50% of my time doing clinical work because of the volume of clinical work, and I always prioritised the clinical work over research and teaching if there was any conflict.
And then in 2017, you stepped down as the chair of the Cardiff Centre and was succeeded by Dr. Raymond. Is that right?
That's correct, yes.
And then the other point I wanted just to touch on your CV was your involvement with the UK HCDO. You became a member of UK HCDO when you became a director of the Cardiff Centre in 1996. Is that right?
Yes, that is correct.
And you have been on a number of working parties for the UK HCDO, including the Inhibitor Working Party, von Willebrand Disease Working Party, Genetics Working Party, Paediatrics, Rare Disorders and Data Management. And you were the vice chair between 2016 and November 2020. Is that correct?
That is all correct, yes.
I'm going to move on now to ask you some questions about the facilities and services at the Cardiff Centre. So first of all, when you took up your directorship, as director of the centre in September '96, can you describe the physical facilities that the centre had at that time?
Yes, the facilities were relatively poor at that time. We had a waiting room, we had one treatment room, and we had an office next door. And within that treatment room, we obviously had to manage all of the people attending the centre. So it was a very cramped in terms of the physical space.
And where were the records kept at during that period?
The records were kept in the office, which was next door to the treatment room, so that if people arrived, the records were readily available to be consulted.
And then in 2000, a new haemophilia centre was built. Is that right?
Well, I think the first thing that happened was that before I arrived, it had been agreed that the haemophilia centre would be, the physical haemophilia centre would be disbanded, and people with bleeding disorders, haemophilia and other bleeding disorders, would be treated on a new haematology day unit. This caused significant concern among the patient group, and as I arrived, this was one of the first issues that I was confronted with. I think that to combine a comprehensive care haemophilia centre and a haematology day unit is not suitable, particularly as we were treating adults and children. And so we had to go through, with the patient group and myself, a process of advocating to have a new haemophilia centre built that was separate for the day unit. And that's the position you're describing then. So the first step, that there was a joint haematology day unit and haemophilia centre, which I don't think was adequate for the work we were trying to do.
And your witness statement says that happened in 1998. Does that sound right?
That's correct, yes.
And then in 2000, the new haemophilia centre was built. Can you describe, yes. And is that where the centre remains?
That's where the centre remains now, yes. Yes.
And what are the facilities there, the physical facilities there?
So again, we have a waiting area with an area for adults and a second waiting area for children, although it is the same physical space. We have a consulting room, and we have 2 treatment rooms. One of those treatment rooms is shared with the Haematology Day Unit. We have an area of a reception desk behind which we keep all of the notes, and we have office space as well, both physically within that area of the Haemophilia Centre, and then across the corridor we have 2 other offices that we have access to.
And when you took up your post in 1996, I understand from your statement that Dr. Desani was in post, and you were the 2 doctors at the centre.
Yes, that's correct. Dr. Desani was an extremely experienced and knowledgeable haemophilia doctor. He'd worked at Lord Mayor Law, he'd worked at Oxford Haemophilia Centre, and obviously he'd worked at the Cardiff Haemophilia Centre for some time. I was very reliant on his clinical expertise because he was clearly a more experienced and knowledgeable haemophilia doctor than I was when I took up that post immediately from training. So I was very fortunate to have someone of that competence and knowledge to be present at the centre at that time.
And there was a haemophilia nurse there, Sister Jennifer Jones.
Yes, that's correct.
You had a physiotherapist, Mrs. Fiona Hall, and you had a social worker, Mr. Timothy Hunt, who I understand's role was limited at that point to social work for patients who had been infected with HIV. Is that right?
That is all correct, yes.
And is it also right that while you've added additional staff to the centre over the years, you've always had nursing staff, physiotherapists and social workers at the centre?
Yes, throughout the whole of the period, and we have expanded the number of nurses and the number of physiotherapists throughout that time, and added, in particularly important, paediatric specialist nurses are now been working at the centre for many years.
We've touched on this already, but you have now you've got additional consultants at the centre. We talked about Dr. Raymond being appointed in 2004, but coming to take up her post in 2005. Dr. Alican in 2008, Dr. Heled Roberts and Dr. Obaji in 2019. Is that so? There are 5 consultants now at the centre.
Since I wrote that statement, there has been another consultant appointment, Dr. Gosani, and he is specialising in paediatrics, and that is deliberate succession planning, so that when I retire, he will take over the management of children with bleeding disorders. So we now have 6 consultants.
And your statement says also that you have a data manager.
Yes, so relatively early on, we appointed a data manager, and I think that's very important because until then, that was falling onto the medical and nursing staff to undertake data management duties, such as returns to the National Haemophilia Database. And so we appointed a data manager relatively soon after I was appointed, within a couple of years, I think.
And you also have a play specialist or play specialists. Can you tell us a bit about them?
So we have a play specialist who works with the children, and their role is to get children to be used to having intravenous access, particularly with the central lines and peripheral access, because obviously some children are very nervous and afraid of having treatment, and their role is to help with that process of gaining confidence of the child to have treatment.
And then in 2012, a psychology service was set up, the All Wales Psychology Service for Inherited Bleeding Disorders, which operates out of the centre. Is that right?
Yes, so that was set up in 2012 and continues to today.
So that is that part of the Haemophilia Centre?
Yes, that's part of the Haemophilia Centre, and it's separate to the psychology service through the Welsh Infected Blood Scheme. They have a separate psychology service which is not associated with the Haemophilia Centre, so that people can choose either to have psychology input from psychologists associated with the centre or independent of the centre.
And the psychology service that's part of the centre provides counselling and psychology services for those with bleeding disorders infected with HIV and hepatitis and their families. Is that right?
Well, they provide psychology service for everybody who attends the centre, but with a specific remit to work with people who have been affected by transfusion-transmitted disease.
And that service has a consultant clinical psychologist for 1 day a week, a principal counselling psychologist for 1 day a week, and a highly specialist clinical psychologist for 3 days a week. Is that correct?
That's correct. And one of those posts is based in the Swansea Haemophilia Centre, so that we can have appropriate access to care more local to people's homes. As part of that service, a psychologist was also appointed in North Wales, associated with the Bangor Haemophilia Centre, but in Cardiff, we're not involved in treatment in North Wales, but as part of that All Wales psychology service, that happened at the same time.
And do you know how much uptake there's been for that service?
I think to be fair, that it looked relatively slow. I think that initially the uptake was slow, but I think that the uptake is now very good, and there are, and I think that as people have got used to that service, then more and more people have come forward. Of course, it's not only for people who are attending the centre as patients, it's for their families as well. And some of the relatives of people who have lost family members have accessed the service of psychology support as well.
Now, the centre is the comprehensive care centre for Mid and South Wales. Is that right?
Yes, that's correct.
And it runs 2 bleeding disorder clinics a month.
2 a week.
A week. And
2 a week.
And has a 24-hour service through an out of hours service.
Yes, that's right. There's an out of hours service 24/7, and people with bleeding disorders can access that at any time.
And in addition, you have a system where people can be visited at home.
Yes, that's correct, and that's been very important over the last 9 or 10 months, that in order to reduce the number of people coming to the hospital, a lot of our care has now been delivered in patients' homes. So the physiotherapists go to patients' homes, the psychologists and the nurses will go to patients' homes for blood tests, so as to prevent people coming to the hospital.
And some of the centre staff also carry out school visits. What does that encompass?
Well, this is if a child is either starting school or changing school. This is to make sure that the staff at the school understand the bleeding disorder, and that the child is able to access and be involved in all of the activities in the school. And it's mainly to reassure the staff of the school that there shouldn't be any significant impairment in what the child is allowed to do.
And the centre also has a role, as I understand it from your statement, in coordinating the care of all of those diagnosed with bleeding disorders in South and West Wales. Can you explain a little bit about what that means?
So the haemophilia services in South, West and Mid Wales are set up as a clinical network, And this has been led by Dr. Raymond over the last 3 to 4 years, so that there is not a haemophilia consultant now in the Swansea Haemophilia Centre, and the staff from Cardiff go to Swansea to provide the care in Swansea, so that someone from Cardiff will go there once a week to see patients and to do outpatient clinics. We're available all the time for the nurses at the Swansea Haemophilia Centre, and we'll react to any issues that arise there. The reason for that we have to set the service up that way is that we were unable to appoint a consultant to replace Dr. Al Ishmael when he retired, and so we had to provide the service as outreach from Cardiff. We also provide outreach to Neville Hall Hospital in Abergavenny, and before the travel restrictions, I would go there once a month to do a joint clinic with a consultant there. But we still provide a day-to-day clinical advice to the centre in Abergavenny.
So are patients, are all patients with bleeding disorders registered at the Cardiff Centre? Or are they registered in Swansea and Abergavenny as well?
Yeah, so patients could be registered at Swansea, at Abergavenny, or in Cardiff, or jointly. They could be registered both at Swansea and in Cardiff. So certainly patients are joint registered, but some are only registered in Swansea and some are only registered in Abergavenny.
And you also provide advice on management of bleeding disorders to all hospitals in the south and west of Wales. Is that right?
That's correct. So if a person has a problem, they might go to the hospital in Haverfordwest, which isn't a haemophilia centre, but that might be their closest hospital, and then the consultant haematologist is very likely to ring us at the Cardiff Centre and ask our advice, and we will advise on what should be done. Either we can advise directly on what treatment should be given, or sometimes we advise that the patient should be transferred to Cardiff if there is a more serious problem.
And so you're describing there a patient going to their local hospital because an event has occurred rather than for their routine management?
Yes, it's not for routine management. No, not for routine outpatient appointments. It's because they've had an injury, or they've been admitted through casualty with abdominal pain or something like that.
In your statement, you've given us some figures as to how many patients have been registered at the Cardiff Centre over the years, and you say that in 1996 there were 328 patients with inherited bleeding disorders registered with Cardiff. 239 of those were over 18, and 87 of those were under 18. Is that correct?
Yes.
Can I ask you to look at the audit that was undertaken in 1997, because that gives us some quite useful snapshot of what was going on in 97. Shomak, it's HCDO 40280_061. So we can see from the first page that this is a covering letter dated the 4th of June 97, dictated 23/5/97 from Frank Hill, and it looks like copied to Dr. Ludlam and Dr. Colvin. Were they undertaking the audit?
Dr. Hill undertook the audit. I think he's probably copying it to Dr. Ludlam and Dr. Colvin, because they would have been the chair of UKHCDO at the time.
So the audit is fairly soon after you arrive at the centre. If we go over to page 2 of the document.
The audit was delayed. The audit should have happened the year before, in 1996, but it was delayed until I took up post.
And we can see at the first hole punch there, haemophilia patients registered. So out of those 328 patients with inherited bleeding disorders registered in Cardiff, of those, is it right that these are the haemophilia patients? Severe Haemophilia A 41, severe Haemophilia B 17, moderate Haemophilia A 33, and moderate Haemophilia B 12. Does that sound right?
It doesn't sound quite right to me. There are too many people with moderate haemophilia. The proportion of moderate haemophilia is much lower than for severe, so those figures don't quite ring true to me, I'm afraid.
And then we can see their medical staff, as we touched on earlier, you and Dr. Dasani. Nursing staff, you've got two nursing staff at that stage, the social worker and the physiotherapist, Miss Hall.
Correct.
And then if we go over to the next page, please, Shomak. We can see there that under other services for children, we've got mention there of home therapy and prophylaxis, so 15 to 18 of the 24 severe Haemophilia A boys are on prophylaxis. And then just over the page, to page 3, while we're on this document, we can see surgery. It sets out that there's genetic counselling and then surgery, emergency surgery, dental surgery, and all of the arrangements for gynecology, orthopaedic surgery, and physiotherapy. Does that look familiar and accurate?
Yes, that all looks familiar and accurate.
So I was asking you questions about numbers of patients. You can take that down now, Shomak. We'll come back to that document on another point a little later on.
I wonder if I can just ask a question. You've told... can we go back to page 1 of this document? And page 2? Thank you. If we look at the haemophilia patients registered there, the total comes to something just over 100. What you were describing a moment or two ago to Ms. Scott from your statement was that in 1996 there were 328 people over the age of 18 with an inherited bleeding disorder and 87 under the age of 18, which is 405. So there's a very big difference in numbers. The inherited bleeding disorders, what comes within the scope of that? How many people with an inherited bleeding disorder will not be people who you would define as suffering from either severe or moderate or mild haemophilia A or B?
A considerable number of people would have von Willebrand's disease. There would be people with inherited disorders of fibrinogen, factor 11, platelet disorders. The figures that I have given in my statement I derived from the National Haemophilia Database. And so I think that would explain why there is a discrepancy from what we've said here. Of course, this isn't showing mild haemophilia either. There would be a lot of people with mild haemophilia who aren't included in those figures.
And the other question, if you go back to page 1. Now, Ms. Scott may be coming to this, I don't know, but there Dr. Hill says in his second sentence, I hope it will help you in your efforts to improve and update the centre. So had you discussed with Dr. Hill plans to improve and update the centre?
Yes, I mean, I read this audit through in the last couple of days, and it sort of brought things back to me as to the situation when I arrived in Cardiff. There were, for example, no routine outpatient clinics for anybody. Dr. Dasani was seeing people in the haemophilia centre on a sort of an ad hoc basis. He would contact people and they would come up and be reviewed, or they would present with a specific problem and he would then review them overall. The number of children on prophylaxis was clearly not not appropriate. We had to put in place prophylaxis for the other children. So I think that there was a lot that we needed to sort out. There were no the joint clinics, for example, that we were setting up with the HIV physician, and the joint clinics with the orthopaedic consultant. These were all things that I discussed with Dr. Hill that we were putting in place and planning to do, and that's, I think, what he was saying. Now, of course, all of those aspects they required within the hospital structure to get to be put in place. And I think what he was saying that he hoped that the audit that he had written would be helpful for me to make propositions to the management that we could make these improvements. I think that after Professor Bloom died, I took my post up about 4 years later, and there had been 3 different people acting as consultant in that time. So there hadn't been a stable consultant in charge looking at a more long-term strategy. And I think that is reflected in the situation that I found when I arrived.
So the reference to update the centre, in Dr. Hill's view, it had fallen behind the curve, had it, during the previous 4 years, at any rate, the years before you came. And
I think that there were some aspects that were very good, and there were some aspects that, yes, had fallen behind the curve. I'd come directly from Great Ormond Street, where I'd worked with Professor Han, and there was a much more proactive view on prophylaxis in children, particularly young children, to prevent the progression of or the development of joint damage. And that was something I really needed to introduce in Cardiff, because certainly we were behind the curve at that time in introducing prophylaxis for young children. And of course, that's very important for their long-term well-being, because the joint damage in your 20s and 30s is caused by bleeds in your first 2 or 3 years of life.
Yes. Yes. Thank you very much.
Sir, for your note, in fact, the figures in Professor Collins's witness statement are 328 people in total with inherited bleeding disorders, 239 over the age of 18.
Well, it's page, paragraph 26 reads, there are 328 with an inherited bleeding disorder registered in Cardiff. I see. Yes, you're right. I beg your pardon. I'd misread it. My fault. Yes. But it's still a rather different figure than the just over 100.
Yes.
Which was
the point. I think I agree. It is a very different figure. I can't explain it more fully.
And then by 2019, your statement says that there are 802 patients with inherited bleeding disorders registered with Cardiff, 640 over the age of 18 and 162 under the age of 18. Is that those figures more or less remain accurate, or have there been an increase since then?
There is always a steady increase in the number of people registered. Yes, there steadily more people are being registered with as diagnoses such as mild von Willebrand's disease, or a number of people with who have clearly had evidence of bleeding, but we can't find anything wrong on their laboratory tests. We look after quite a few people in that category.
And of those 802 patients, what would be your best estimate as to how many of those patients were people with haemophilia?
Now?
Yes.
Now? Probably about 150, 160, something like that, I would have thought. I mean, one of the reasons I'm struggling is, of course, we're now directly looking after all the people with haemophilia in Swansea as well. And that again might be a cause of the discrepancy in those figures, because whether someone's registered with Swansea and Cardiff, as we discussed earlier, it's not always clear cut where you allocate to which centre.
So some of those 802 people may be registered in more than one place.
Yeah, that's right. Yes, exactly.
And your statement tells us that currently registered patients from of the registered patients from the centre, 13 of them have HIV, 13 of them are co-infected with HIV and hepatitis C, 66 are infected with hepatitis C, and 4 are being treated for hepatitis B. Is that right?
Yes, all those figures are correct, yes.
And can you recall what the numbers of patients infected with HIV and hepatitis C were in 1996 when you arrived at the centre? How many patients you were treating for HIV and HCV?
The figure that I was told and that I've always assumed was 45 people had been infected with HIV. Some of them, of course, had died before I arrived in Cardiff. And also one partner had also been infected with HIV. And the figure of the people infected with hepatitis C was either 108 or 118. There are two figures that are given there. Of course, many more people would have been infected with hepatitis C, but they had died before the hepatitis C test became available.
So when you arrived in 1996, there were some number between 13 and 45 patients infected with HIV that you were treating in 1996, and some number between 66 and 108 or 118 with hepatitis C that you were treating.
That's correct, yes.
Just to clarify, Biscott, the 13 with HIV and the 66 with HCV, that's the entirety of the cohort, is it? So the 13 co-infected are the 13 who have HIV and 13 of the 66.
That's my understanding. Is that correct,
So it's not
Professor?
an additional category.
No, is that correct, Professor Collins?
Yes, that's not an additional category. The 66 with hepatitis C include the 13 people who have HIV. Again, just to make sure it's clear that some of those people with HIV may also be registered in Swansea, and so the numbers that Dr. Al-Ishmael gave you can't add those two numbers together to give a South Wales number, because they will be being treated in both centres.
I'm going to ask you some questions about the arrangements for the supply of product and treatment to the Cardiff Centre over the years, and also what treatment's being provided to patients. But before I do, I'm going to before I get on to your time from 1996, you've exhibited to your statement some of the treatment policies that were in place during Professor Bloom's time at the Cardiff Centre. Do you have any first-hand knowledge yourself of how those treatment protocols or treatment policies were implemented in Cardiff?
Well, clearly I wasn't in Cardiff there, so I don't have first-hand knowledge. But to the best of my knowledge, those treatment protocols were implemented in Cardiff.
But given, Professor, that you have no first-hand knowledge yourself of what was happening in Cardiff, I'm not intending to ask you any questions in relation to the implementation or otherwise of those policies and protocols.
Sorry. Yeah, I understand.
So what were the arrangements for how did the centre purchase products, blood products, in 1996 when you took over as director?
So the blood products were all initially purchased by the Welsh Blood Service, and so they went to the which is the transfusion centre. So they were purchased by the transfusion centre and held at the transfusion centre, and then all the hospitals in South Wales would have the blood products delivered to their hospitals. So Cardiff would have the blood products from the transfusion service, and Swansea blood products from the transfusion service, and other hospitals would do the same. So the purchasing was directly from the transfusion service, and then it was allocated to the hospitals, and then we would be cross-charged by the transfusion service for the cost of the product.
So is that both for NHS product and for commercial product?
Correct. Certainly when I arrived in 1996, all of the product went to the transfusion centre and then came to the centre. Since then, things have changed because a lot of the product now is home delivered, and so it doesn't go to the transfusion centre, it's delivered directly to people's homes. And so that's a different mechanism. But at that time in 1996, the Cardiff Haemophilia Centre didn't buy any product directly. It all went through the transfusion centre.
When you, in your statement, when you say you and Dr. Desani chose the blood products that were going to be used at the centre, was that out of the products that the blood transfusion service was holding, or could you say to the blood transfusion service, could you purchase us X and Y?
Yes, we could go to the transfusion centre and say, we would like you to start holding a stock of this other treatment, and then we would use it. So we could certainly, we were the people choosing what products to use, not the transfusion service.
Can I ask you about a paragraph in your witness statement? It's WITN 4029001. And it's at internal page 15. It's paragraph 75. And you say, structures or decision-making bodies that considered the risk of infections associated with blood and blood products would have been led through the blood transfusion service rather than through the Haemophilia Centre. What do you mean by that paragraph?
Well, I think that by that time, the risk of infections from the products we were using in the Haemophilia service were much lower.
Because the products were, why was that?
Because the products were by then all heat treated, yes, and had been for over 10 years, and by then had very good safety records in terms of HIV and hepatitis C. So that response is the question was in 74 whether there were any advisory or decision-making structures that covered the centre. The answer was no, there weren't any, and I've made the point that if there were any, it would have been through the blood transfusion service, not through the Haemophilia Centre. There were no specific structures there to consider the relative risk of blood products from the point of view of infection.
So is this fair that at that stage you and Dr. Desani would have considered that all of the products were much of a muchness in terms of safety of viral transmission? And if there had been any issues with a particular product, you would have expected that to have been brought to your attention by the blood transfusion service?
I think, well, this of course was at a time when recombinant blood products were just becoming available. So both myself and Dr. Dasani were completely agreed that we would prefer to use recombinant blood products than plasma-derived blood products because of the potential of risk of infection. I would have thought that if there were any issues relating to the risk of infection, I'm more likely to have been told by UKHCDO or by the companies themselves than by the transfusion centre.
So when you started at the centre, you say in your witness statement that your patients were receiving blood products. People with haemophilia A were being treated with the BPL-8Y heat-treated plasma product and Replinate. People with haemophilia B with a high purity factor 9 product, Replinine, and patients with von Willebrand's were being treated either with BPL-8Y, DDAVP, or Haemate P. Is that right?
It is. A very small number of people were also by then on recombinant factor 8. I think there were 4 people on recombinant factor 8 because they had been involved in a clinical trial of recombinant factor 8. The product was Cogenate, and at the end of the clinical trial, they had remained on that recombinant factor 8. So a very small number were on recombinant at that time.
And we can see that in the audit document. So if we can go back to Shemek, please, HCDO 40280_061, and go to page 5 of that document. Under availability of blood products, it says these are stored in the haemophilia unit. Children are currently treated with BPL-8Y, apart from pups who have presented in the last 2 years, so presumably since 1995, and 4 previously untreated patients who were recruited into a trial of recombinant factor 8. 4 adults are also in this study. So it looks like there's 3 cohorts of patients in that study. Does that record with your recollection?
Yes, so the 4 people on recombinant factor 8, that's correct to say that they were people who've been recruited in the trial and carried on. The previously untreated patients, I don't remember there having been any previously untreated patients in the previous 2 years before I arrived. But what we would have done is that had there been any, we would have treated with recombinant factor 8.
And you also say in your statement that as you've just mentioned, that this is the point at which recombinant factor 8 was becoming available, and you were very keen for your patients to be put onto that. Can you talk us through how that occurred?
Yes, so almost the moment I arrived, within a couple of weeks, the patient group had come to me and said that they wanted to be pushing for recombinant factor 8. Of course, recombinant factor 8 was substantially more expensive, and so I had to put together cases based on the improved safety of recombinant factor 8 to make the case for the increased funding. It was quite complicated because we were treating people from all areas of South, Mid and West Wales, and so we were having to go to a number of different health authorities to get the funding. We put the case, and in 1997 there was an agreement that everyone in Wales, including North Wales, whose patients we weren't looking after, would have access to recombinant factor VIII, and the additional funding required was put in place to fund that.
And if we can turn to a document which might help us with that, it's WITN 4029013. This might help put some dates on when that actually took place. So this is a letter on the 15th of December 97. It says, "Dear Dr. Blank," and if we turn over to the second page, we can see it's signed by you and copied to a number of your colleagues. We can see there Dr. Al Ishmael, for example. So if we turn back to the first page of that document and to the second paragraph, so just putting this in context, you're enclosing a letter that's been circulated by the UK HCDO regarding VCJD in the treatment of haemophilia. And then you go on at the second paragraph. From our point of view, we're very fortunate that we have agreement to treat all patients with recombinant blood products, and it would seem sensible to change all our patients to recombinant factor VIII rather than to American-based plasma before changing them to recombinant factor VIII. We are in the process of doing this, and hopefully we'll have all patients on recombinant factor VIII in 3 to 4 months' time. So in December 97, it looks like you're hoping that will be in place by April 98. Can you recall whether that was the time at which point all your patients have been switched over?
I can't remember exactly. I don't think that they had all been switched over by April 1998. Based on information I've seen from the National Haemophilia database, I think it probably took another year for everyone to be changed over. I think one of the things that this letter, just to make a point of this letter, I think this is an important role of a comprehensive care centre that I had been informed by UKCDO about variant CJD, and I had cascaded that information to all of the haematologists in South and Mid Wales, so that they were, to make absolutely sure that they were aware of this information, because of course the information had gone to haemophilia centres and not all hospitals.
The next paragraph is also probably worth looking at here. You're talking about the situation with recombinant factor IX being more difficult because it's not yet available in the UK, likely to come available in the next 6 months. And therefore there's a choice of continuing with BPL products made from UK plasma or changing to a factor IX manufactured from American donors. Realistically, this would mean purchasing the factor IX from Alpha. At the present time, we're discussing this issue with individual patients, and if they show a strong preference for changing to USA plasma, we will change their product. However, if no strong preference is expressed, we will continue with the high-purity BPL product until recombinant becomes available. Why were you suggesting that patients should have a strong preference before changing them over to American plasma?
Well, I don't think that's... Looking at it, I wouldn't use the word strong preference. If a patient had said they had a preference to change, then I would have changed. I don't think there's any resistance to that. The reality was that from my memory, that people were resistant to changing to US plasma because of the concerns they've had in the past. It's important to remember at this time, 1997, is that the information being given to us was that there was only a hypothetical risk of variant CJD in UK plasma, and indeed there was, as we may come on to later, there was advice that we shouldn't be telling the patients at all about this issue, which UKCDO disagreed with, and I disagreed with. So there was the level of risk being told to us was that essentially it was thought that there wasn't a risk. And of course, everybody at this time who was eating meat was being exposed to variant CJD through that mechanism. And so these were sort of some of the conversations I would have had to have had with the patients about what their choice wanted to be, because some people might well take the view that they were being exposed through the food chain anyway. My memory is that, and I think I'm correct in this, no one wanted to change to US plasma. And of course, later on, the next year, BPL started to make all of its products from US plasma, and that did cause some people some concern that their product was now being made from US plasma, and for obviously because they were very well aware of the problems of the past.
And the inquiry's heard evidence from some clinicians who describe putting their patients or some of their patients onto recombinant factor products and then there being a shortage and having to switch them back to plasma products. Did you have difficulties with that? Did that have to happen with any of your patients?
We didn't have to change anyone back to plasma-derived products. We did have to reduce usage. We had to reduce prophylaxis in some people, and for a while suspend prophylaxis in some people, and we had to delay surgery. But we were able to maintain everybody on recombinant, and no one was required to change back to plasma-derived.
Can I now move on to the current purchasing procedures, if I can put it like that? We understand from your statement that since 2005, products used at the centre have been purchased nationally via the national tender process. What role do you or the centre have in that process, if any?
Well, I play a role because I represent Wales on the sort of UK-wide committee. There's a UK-wide committee run by the Commercial Medicine Unit, and they put a tender out on behalf of the whole UK, and both myself and people from the Welsh Commissioners represent Wales on that committee, so we give our opinions. The tender goes out, and as the result of the tender, depending on what the specific tender, very often haemophilia centres were then required to use a certain proportion of different recombinant factor VIIIs, and so I was certainly involved in the centre of ensuring that we complied with those tender arrangements. I think it is just worth pointing out that from the point of view of the NHS, that tenders process has saved a phenomenal amount of money for the NHS because the UK has acted as a single entity in these tender arrangements. Before, each individual sort of area would have to make a tender, and so would not get nothing like as good a price. And so
picking up on the point about centres having to use a minimum proportion of particular named factor VIII products. So if, for example, the tender is for, 5 factor VIII products, do you have to use all 5 of those, or how does it work?
No, it would work. Let's say that there are, as you say, a certain number of factor VIII products. For the top 2 in the tender, we would have to use a certain proportion of those. The top one we would have to use the most, then after that. But for the rest of it, there's a proportion where we can use anything we want. And so we would then have to discuss with individuals about changing products. I would always tell people that the reason the product was changing was for price, and that we would discuss that it was for the benefit of the NHS overall. Although, of course, some of that savings has been reinvested in haemophilia care in various ways, particularly in access to increased amounts of factor VIII, So the amount of factor VIII we've used over the years has gone up substantially, and that's funded in part by the savings in the contract. But of course, if some people, for whatever reason, say they didn't want to change product, then we wouldn't change their product. If they wanted to stay on their product for any reason, they could stay on it. There was no... If someone had that view, they were allowed to stay on their product. There was no products that were specifically unavailable.
I'm going to come back and ask you some questions about your consent process in a moment, but as well. So, but just sticking them with products that are available that you provide to your patients at the centre. So, people with haemophilia A, what are they? Are they treated with third generation recombinant factor VIII products? Is that how I understand your witness statement?
Yes, so at the moment they're treated with either third generation recombinant factor VIII products or enhanced half-life recombinant factor VIII products, or now over the last sort of year or so, increasingly more people are treated with with emicizumab, which is a non-factor VIII product. It's the bispecific antibody, and the advantage of that is it can be given subcutaneously rather than intravenously, and can be given weekly or every 2 weeks. So more people with haemophilia are opting to go onto that product over time.
People with haemophilia A and inhibitors treated with factor VIIa and FIBA. Is that right?
And emicizumab.
And people with haemophilia B, are they treated with recombinant factor IX products and some with plasma products?
So yes, so when recombinant factor IX came in, everybody was offered recombinant factor IX, and to my memory, everyone decided they wanted to go on to recombinant factor IX. However, some people, their experience was that they did not think that the recombinant factor IX worked as well to treat or prevent bleeds as the plasma-derived, and so a small number opted to change back to plasma-derived factor IX.
And some are still treated, and some remain on that product.
A very small number, 1 or 2, I think. And now we're using the enhanced half-life factor IX products, which can be given once a week or sometimes even once every 2 weeks, the enhanced half-life factor IX products. And so everyone with haemophilia B has been offered, with severe haemophilia B on prophylaxis, has been offered the opportunity to go on to enhanced half-life. Some people prefer to stay with the product they know and have stuck with the standard half-life factor IX, which is Benefix.
What is the first line of treatment for people with mild haemophilia?
Well, with mild haemophilia, the first line of treatment would be desmopressin, DDAVP, and everybody with mild haemophilia would have a DDAVP trial so that we can see how well they respond to that, because there are some bleeds that might well respond to DDAVP, but very serious bleeds, if we're not getting good enough levels, they might not respond. So if there is an inadequate response, we would use recombinant factor VIII.
And for von Willebrand's patients, it's plasma-derived products and DDAVP and or factor VIII-Y. Is that right?
Well, so it's plasma-derived. The product we use at the moment is called Voncento. We don't use factor VIII-Y for von Willebrand's disease anymore. We did when I first arrived, but we haven't for a long time. We are just about to get access to recombinant von Willebrand factor, and we are just waiting for the authorisation from the Welsh Commissioners to be able to start using that in some people with von Willebrand's disease.
I'm just going to ask you some more questions on the consent process. You've already touched on this, but can I ask you what conversations you would have with a patient when you are discussing with them the type of treatment that you're going to give them. So I'm going to split this up between, if you like, type of treatment. So you're choosing between different kinds of treatment, either plasma products, recombinant products, or half-life products, and then go on to look at within those types different brands of treatment. So when you're deciding what type of treatment a patient should have, what information would you give the patient about the risks and benefits of the type of treatment?
Well, this conversation predominantly happens in the context of young children with severe haemophilia, and often this conversation takes place before the child is born, because we offer antenatal diagnosis at about 32-33 weeks of gestation. An amniocentesis can define whether the child has severe haemophilia or not. So before the child is born, we will have discussions with the parents. The key risk at the moment with recombinant factor VIII is the development of a factor VIII inhibitor. That's the most important side effect of treatment, and then the child will be resistant to factor VIII treatment. We discuss specifically on the basis of a paper called the CIPET study, which was a randomized control study comparing the rate of inhibitor formation with plasma-derived factor VIII in these previously untreated children versus recombinant, and it showed that children treated with plasma-derived had less risk of inhibitor. So we discussed that particular finding with the parents, and then the discussion is, do they want plasma-derived or do they want recombinant? Every single parent that I've ever spoken to with regard to this would prefer recombinant because they would prefer the recombinant product, even if there is a small increased risk of inhibitors. We also discuss the enhanced half-life products. Although with factor VIII they are enhanced half-life, in young children it doesn't make a huge difference, because in young children the half-life to factor VIII is quite short anyway, and it gets longer, the half-life of factor VIII, as the child gets older into adulthood. So we do discuss enhanced half-life factor VIII, and many parents choose to go with enhanced half-life factor VIII. Just recently, we have started to discuss the role of emicizumab in the management of severe haemophilia, and that some parents may wish to start with emicizumab rather than factor VIII, because one of the big advantages of that is you don't have to put a central line in, and it can be given subcutaneously. The downside is that we have much less experience with emicizumab in young children, and so we would have quite a long and in-depth discussion about the choice of emicizumab or factor VIII replacement in a young child.
And what information, if any, do you give to patients or parents of patients during those sorts of conversations about potential risk of pathogenic transmission?
Well, I always discuss with the parents that in the past factor VIII has transmitted HIV and hepatitis, and I always do that because if someone looks it up on the internet, that's one of the first things they'll come across. So I do that in the context of reassuring them that the products we use are safe from that point of view. It's also, of course, very important to note that many of the women who are giving birth to children now with severe haemophilia have lost family members because of HIV, or they're living with family members who have HIV. So, for example, their father may have had HIV. So I have that discussion with them. Really, it's to try and reassure that the current recombinant products are not made in any way with human or animal derived products, and so can be considered essentially safe from the point of view of transmission of those diseases.
And would you provide any written materials to patients? Is that part of your practice when making these sort of treatment decisions?
We do provide some written material, yes, but we tend mainly to spend time talking. These conversations aren't one-off conversations. We will have discussions. Sometimes we have these sorts of discussions happen before the woman is pregnant. We will have these discussions, and they are over a prolonged period of time, so that it's because obviously people have a discussion, go away, have more questions, and come back, and that's something we always make clear that is available. And it's of course not just myself and other consultants doing this. The nursing staff will also often will visit the individual's home and have a discussion about treatment choices, because it's not just the product that you're having. It involves whether it's likely that the child will need an intravenous catheter to deliver the treatment, and what it's like living with a child with haemophilia is something that we go through in some detail.
And would those sorts of discussions be recorded in notes, in patients' notes?
Yes.
And how do you record those discussions?
Well, I record them in the medical notes to say that what we've discussed. I particularly record the discussion about inhibitor formation, and that I have reassured with regard to infectious diseases, and then also the letter to the GP is now routinely copied to the patient, so that again they can. And I think that's really quite helpful, because quite often, once I've done the letter to the GP, or one of my colleagues has, then the individual will come back having read the letter and say, this is something that I'm not sure about and I want more information. So I think that that's quite important.
So you'll have those types of discussions for children even before they're born. Presumably you also have those types of discussions when new products become available, new types of treatments become available. You'd have those with your existing patients.
That's right. So over the last 2 or 3 years, we've had extensive discussions with people who, for example, are on prophylaxis for the standard half-life factor 8, and we've discussed the options of changing to an enhanced life factor 8, or more recently to emicizumab. And quite a few people now are opting for emicizumab. And that is all in the context of the discussion about what the individual person is wanting to achieve with their prophylaxis, because often the intensity of the prophylaxis depends on the intensity of the physical activity the individual wants to undertake.
And it sounds as well, it sounds from what you've said, that those discussions with patients, adult patients or existing patients, is not a one-off conversation. For those, when new products come online, it sounds like it's an ongoing dialogue that may take a few sessions. Is that right?
Yes, that is right. I mean, my experience with emicizumab is that a number of people I've discussed emicizumab with them, and initially they've said, I'll stick with factor 8, and as time has gone on, a subsequent conversation is, well, I've now decided I want to try the emicizumab treatment, and that's what happens. So yes, people will obviously change their minds as they get more of a feel for a new product, and obviously people in South Wales with haemophilia talk to each other.
And what's your practice in terms of the balance between giving patients information about products and leaving it entirely up to them to make a decision, or versus you as the clinician making a recommendation to the patient as to what you think would be best for them. What's your practice? Where do you sit along that continuum?
Well, the first thing I just want to say is that I think that it's not the clinician, it's the Haemophilia Centre. So the Haemophilia Centre, in terms of the nurses, the physiotherapists, everyone is involved in this. It's not clinician-led anymore. Specifically, it's a team, a holistic team approach. Our view is that the individual with haemophilia has the control of the situation, and it's for them to decide what type of product they want to use. And of course, some people will try a product, find it suits them well, others will find it doesn't suit them well, and they'll try something different. And so it's entirely down to the individual as to which type of product they want to try.
And then once you've made a decision about what kind of treatment, then the patient then has another choice, do they, as to which brand or which particular product that they're going to use. Is that right? Do you offer them, so they've decided they want to have a half-life product, do you then say, well, there's this one, and this one?
We do, but it's in the context of cost as well, because different products cost different things, different amounts. So we discuss the different types of extended half-life products.
And so typically the information you would give about each extended half-life product, for example, balanced against the other, what sort of type of information would you be giving?
Well, we would give information about the mechanism by which half-life products are prolonged. There's certain half-life products where the half-life is prolonged because essentially the factor VIII or the factor IX is recirculated through it's kind of recycled through the endothelial cell system. That's one type. The other type is where a molecule called polyethylene glycol is added to the factor VIII, and that will extend the half-life. So there are different mechanisms. All of them come out with a half-life essentially that they all prolong the half-life by essentially the same. So the amount of factor VIII that the individual has is the same essentially for all the products, and so those are discussions that are had. Similarly with factor IX, it's the same. There is the option of the pegylated factor IX, or there are two recycling mechanisms of factor IX. One because the factor IX is bound to albumin, and the other, the factor IX is bound to what's called the FC receptor. So they're different mechanisms, and with factor IX, importantly, the pharmacokinetics are different. So the way that you use the product is different, dependent on the mechanism, and so that has to then be taken into consideration as well.
So you give information about the different ways that the products work. I said you've said that you give financial information as well. So you give the patient information about how much each product costs. Is that right?
We don't say specifically how much they cost, but we say that certain products are cost less than others, and that all things being equal, that might be something to consider in the choice.
And you've already told us that sometimes you're saying to patients, look, in order to comply with our obligations under the tendering process, we need to think about switching you to a new product, and you would give them that information as part of that discussion.
I would, at the moment, the current tender does not require you to use a certain amount of any product. You can use any product you want off the tender. In the past, we did have to use a certain amount, and we would explain to the person that the reason we want to change you is because of this national tender and it's going to save the NHS money. And I never had any person really showing concern about that. Some people wanted to stay on their same product because they preferred to, and then that was fine. We would agree to that.
So that the impact on the tender in terms of choice of product was very much a request to the patient, rather than saying you in order for us to comply with our tendering obligations, you must switch product.
Yes, there was never a compulsion. It was always explained. But the people I talk to, I think, buy into the concept of the NHS and the kind of the pooled resource that is the NHS. And in South Wales, the NHS is a very important part of the social fabric because, of course, it came from South Wales. And so people will fully understand these concepts. And so I've never. Some people, as I say, would prefer to stay on the product they're on, and then that would be absolutely fine.
So again, when you're talking with patients about the different choices they've got of half-life products, for example, is the choice entirely up to them, or is that a choice, or is that a little bit more clinician-led or centre-led because of aspects like price?
Everyone has access to enhanced half-life products, and we would not, in the end, dictate to people what they wanted. We would explain the pros and cons of each product. I think that, to put it into context, of course, emicizumab is substantially more expensive than factor VIII to treat a person who doesn't have an inhibitor, and we give open access to people to emicizumab. So price is not the defining issue. If someone wants to go onto emicizumab, that's a significant cost increase in their care. But people, if people want to, then we change.
So I'm going to go on to a different topic now, and I note time, so I wonder if now is a good time for a...
Yes, well, we'll take a break, as you may have realised, during the morning, and it's normally about half an hour, so we'll meet again at 5 to 12. What I tell all witnesses is that they mustn't discuss their evidence being under oath, either the evidence you've given or that which you think you may be asked to give in due course. That includes discussing with your wife. You can talk about anything else you like, but not that. So we'll see you back at 5 to 12.
Okay, thank you.